Thank you very much for the kind introduction. It's really my pleasure to be here in one of the nests of cardiology in Italy and also in Europe at large. And I would like to thank Professor Basso for the invitation. I also take the opportunity to greet Professor Tiene, which I see in a small window there. And so dear colleagues, it's my honor to be here today and give you a little bit of an overview in the next half an hour of some of the research we did on inflammation and its relevance for cardio and cerebrovascular disease. So the inflammatory theory of atherosclerosis was first proposed a long time ago with some notable contributions, in particular that of Geraghty in 1981, whereby the importance of monocytes and their differentiation into macrophages, infiltration into the subendothelial layer was first shown. And ever since the late 80s, this theory was supported by many other notable researchers, amongst which Peter Libby, of course, Goran Hansson, but also Attilio Masari. And throughout the years, the role of the immune system became more and more characterized. And as you can see in this cartoon here on the right-hand side, you see that following release of DAMPs and PAMPs, you have activation of monocytes, which are, however, also activated by T cells and in turn by dendritic cells to release all sorts of different pro-inflammatory mediators, which then play a pivotal role in atherogenesis and its deadly complications. However, it was only recently that these theories were clinically confirmed. Several trials by now have confirmed the inflammatory theory of atherosclerosis. One of them, perhaps the most important one, was the CANTOS back in 2017, where stable coronary artery disease patients who experienced already a myocardial infarction were randomized to canakinumab in 3 different concentrations, 50, 150, and 300, as well as placebo. Then primary endpoint was a composite one with non-fatal MI, non-fatal stroke, as well as cardiovascular death. And as you can see, as I'm sure all of you already know, both dosages, the 150 and the 300 milligram canakinumab, were able to significantly decrease the incidence of the primary endpoint, as you can see here on the left, as well as on the graph on the right. Soon after that, in 2019, was the COLCOT trial, then later also followed by the LODOCO and LODOCO 2, whereby again, myocardial infarction patients were randomized to receiving colchicine 0.5 milligram per day, and they were followed up for a median time of 22.6 months. Again, here, the composite primary endpoint was death from cardiovascular causes, resuscitated cardiac arrest, myocardial infarction, stroke, as well as urgent hospitalizations for angina leading to revascularization. And also in the COLCOT trial, we saw a significant decrease in the incidence of the composite primary endpoint, thereby once again confirming the relevance of inflammation, and in particular in those cases of inhibiting inflammations in cardiovascular outcome. Nonetheless, although these trials were enlightening, there were still some doubts as to how and exactly which mechanisms underlie the success of these therapeutic approaches. In particular, also with the COLCOT, with the CANTOS trial, we know that arterial thrombus formation is a key event in all major adverse cardiovascular events. And we also thereby know that arterial thrombus formation was key in the composite primary endpoint of the CANTOS, but we don't know how and if IL-1 beta neutralization could interfere with arterial thrombus formation. Thereby, a couple of years ago, we set on to investigating whether IL-1 beta neutralization could interfere with thrombus formation. To that end, we established a mouse model of arterial thrombus formation, which I would like to explain to you here below. So first of all, we inject in the tail vein of a mouse, which is fixed in an operating microscope, rose bengal. This is a light sensitive substance which reacts with a specific light frequency of 540 nanometers. Once the rose bengal circulates systemically, we perform a midline cervical incision in the mouse, and we expose the left carotid artery. Once we expose the left carotid artery, we slip onto it a Doppler flow probe to measure blood flow in the carotid artery. Once this is done, we shoot a laser light at the carotid artery, which crosses the vascular wall without damaging it. And once it crosses it, it reacts with circulating rose bengal, giving place to a photochemical reaction. This photochemical reaction selectively injures the endothelium, thus exposing the subendothelial collagen as well as the subendothelial tissue factor, thereby activating the extrinsic coagulation cascade and leading to thrombus formation. And what you see down here below, it's just a readout of what we typically get from this model, where you see blood flow over time, where the injury starts at time 0, and you see blood flow decreasing. You see episodes of thrombus formation, which is, however, embolized due to the efficient fibrinolytic system, sorry. And then once blood flow reaches below 0.1 milliliters per minute for more than a minute, we interrupt the experiment and call it a stable thrombus. So again, going back to our, and this is actually a very important slide, which I hope you will appreciate, is an electron microscopy slide confirming how this model works. So on the left-hand side, you see an intact endothelium and endothelial cells, and on the right-hand side, you see a luminal thrombus, and then you see really the denudated endothelium with a necrotic endothelial cell, which mimics a little bit more closely the erosion that occurs in a complicated plaque. And this is actually important because several other models that our colleagues use, sometimes employing ferrum chloride, they are transmural models. So they also damage the media as well as the adventitia, so they're not really so relevant. So going back to our hypothesis, we wanted to see whether IL-1 beta neutralization could interfere with the process of thrombus formation. Thereby, we recreated inflammatory conditions in wild-type mice, and to that end, we injected intraperitoneally LPS, low-dose LPS, 5 hours before injecting the canakinumab surrogate antibody, which was the same used by Novartis in the preclinical studies. Then we waited another 5 hours, and we performed the photochemical injury model. And interestingly enough, what we saw is that in the IL-1 beta inhibited mice, there was a delayed thrombus formation, indicating a blunting of the procoagulant pathway. And here below, you see an original recording for the mice, where you see in black the vehicle treated occluding in roughly 25 minutes, while the IL-1 beta antibody treated occluding in roughly 40 to 42 minutes. We also performed some baseline measurements to make sure that these mice were comparable. And as you can see, blood flow at before the start of the injury was comparable. Likewise, heart rate. Please remember, these mice are, of course, anesthetized, hence it's so low, as well as the body weight over the 10 hours treatment prior to the thrombosis model. Next, we wanted to investigate whether tissue factor, which is the key trigger of the coagulation, of the extrinsic coagulation cascade, was perhaps affected by IL-1 beta neutralization. And in fact, what we found is that the levels of tissue factor in the plasma were significantly decreased in the treated mice as compared to the vehicle control mice. Unlike what we observed in aortic homogenates, whereby tissue factor protein expression was unchanged. So this was indicating a specific effect on systemic tissue factor. And at this point, we wanted to try and identify the possible source of the systemically circulating tissue factor, given the fact that many different cell types release it and express it. Thus, we first assessed activated neutrophils, so neutrophils undergoing NETosis, and we did that by measuring MPO-DNA complexes, and we found that NETs, activated NETs, were actually decreased in IL-1 beta treated mice as compared to vehicle treated one. And one of the reasons why we did that is because a few years before, a Chinese group, I think in collaboration with Peter Libby, described that when neutrophils perform NETosis and they release chromatin and DNA, these chromatin DNA complexes can act as scaffolds for several proteins to function correctly, with one of these proteins being tissue factor. So as a next step, we measured tissue factor associated to DNA, and we found that in line with the reduced NETs, also tissue factor DNA complexes were actually reduced in those mice, thereby providing a possible explanation for the reduced tissue factor systemic levels, plasma levels that we measured, and I showed you in the previous slide. Then to increase the translational relevance of our study, we also wanted to assess what happens to tissue factor, to IL-1 beta, as well as to tissue factor DNA complexes in different subsets of patients. Unfortunately, we initially tried to get hold of plasma samples from the CANTOS trial, but unfortunately already at that stage, Novartis had decided to terminate the program, so we had to take some other samples available to us, and in particular, we got hold of some plasma samples from the SPUM trial, which is performed in Switzerland. It's an inter-university program whereby ACS patients are enrolled and followed up for several years after PCI. So we took all in all 66 patients and divided them into low and high CRP, whereby low is below 4 milligrams per liter and high is above 10 milligrams per liter. And the reason why we did that is because in the sub-analysis of the CANTOS trial, it was shown that those patients with higher levels of IL-6 were actually the best responders to the treatment. And what we did here, first of all, we measured IL-1 beta, which was, as expected, increased in patients with high levels of inflammation. And then we also measured NETosis, which was increased in high CRP level. And we also measured tissue factor associated to DNA, which was again increased in patients with high level CRP. And lastly, we also looked at the correlation between NETosis as well as tissue factor DNA complexes, which was positive, thereby confirming, at least in part, or at least in an observational way, what we postulated from the mouse experiments. Now, inflammation is not only important in thrombus formation, and an important role of inflammation has also been identified in the setting of aging, as well as age-dependent cardio, as well as cerebrovascular disease. Unfortunately, studying aging in humans is fairly difficult because aged individuals always develop concomitant risk factors, thereby making it difficult to identify what depends on aging per se or confounding factors such as atherosclerosis. Now, among the many limitations presented by mice, in this setting, actually mice offer an ideal system for studying aging because they develop aging with age-dependent decay in function of different organs, including the vasculature. However, they do not spontaneously develop atherosclerosis. So you can really impute whatever changes you see down to aging per se. And in this context, one of the working hypotheses in our team is depicted in this cartoon here. And what we think is that aging genes or lifespan determining genes not only determine or underlie aging, but they also mediate the onset of age-dependent cardio and cerebrovascular disease, as well as age-dependent vascular dysfunction. And oftentimes, this modulatory role of these genes is reached by regulating common denominators, in particular concerning inflammation as well as free radicals. So in the setting of aging, an important theory which has been increasingly regarded as important over the last few years is looking at the role of inflammation in aging is that of inflammaging, which is generally identified by the low-grade inflammation which is observed in elderly patients. And one of the most widely accepted explanations for this is depicted here in this cartoon, and sees a decrease efficiency and function of the adaptive immune system in favor of an overactive innate immune system. In fact, elderly patients are usually characterized by low-grade inflammation, but also by impaired immune systems. And many different mediators have been described in this setting to possibly account for part of these processes. In the setting of aging and age-dependent cardio and cerebrovascular disease, we have developed a specific interest for stroke, and thereby we were interested in assessing the possible contribution of mediators of inflammaging in the setting of stroke. Much is known about the incidence of stroke with aging, which increases dramatically. However, not so much is known about the outcome of after stroke in elderly versus younger patients. So what we started by doing was to assess different cytokines in the plasma of young versus old mice, where young mice are 3 months old and old mice are roughly 20 months, and also in brain homogenates. What we found is that in the plasma there was a staggering increase of TNF-alpha, while other cytokines were below detection level. While in brain homogenates, there was no difference, for instance, in IL-1 beta or TNF-alpha levels. Thus, in order to assess the specific role of TNF-alpha as a potential mediator of inflammaging in stroke outcome, we used a mouse model of stroke, which I would like to briefly explain to you here with this diagram on the left. So we expose the common carotid artery, we insert a filament, and we advance it all the way up to the internal carotid artery, the circle of Willis, and then the middle cerebral artery, where we occlude flow for 30 to 45 minutes, depending on the experimental conditions. Then we retract the filament and allow reperfusion for 24 to 48 hours, again, depending on the experimental conditions. And after that, we can look at different aspects of outcome in mice, beginning from stroke size, neuromotor performance, as well as blood-brain barrier function. So what we did in, oh, I've lost the slide. No, I haven't. So what we did was to expose young mice and old mice to this transient middle cerebral artery occlusion model. And what we observed is that old mice, despite of not having any risk factors, but simply being older than young mice, had a almost 4 times larger stroke size as compared to the young littermates. And this is TTC staining demonstrating representative brains that make up for this graph. We also then looked at neuromotor performance. We performed 2 tests. This is the Bederson-derived scale, where we looked at hind and forelimb coordination, and you can see that old mice have a higher score, thus indicating a larger impairment or a more severe impairment. And then we also performed rotor rod, whereby we placed the mouse on a rotating rod at increasing speed, and we measured the latency of time before the mouse actually falls off the rotating rod. So also in this case here, as you can see, the old mice were falling off the rotating rod before the young ones, thus indicating lower neuromotor performance. Next, congruent to our systemic measurements of different cytokines, and with the fact that TNF-alpha was selectively increased in old mice, we performed a 4 weeks long treatment of old mice with infliximab, and which is a TNF-alpha antibody, and with a control condition. And what we observed was actually very interesting. Again, concerning stroke size, you see there was a drastic increase of stroke size in old mice compared to young, which returned to baseline in the TNF-alpha neutralized mice, as you can see in the third dark blue column. We again performed neurological function assessment, and as you can see, this is in the dark green, old mice with a higher Bederson scale score, and here below you see the the young as well as the old treated mice with infliximab, which essentially have a comparable outcome. And the same took place also with the Rotarod test, where the performance of the old mice treated with infliximab returned close to baseline levels observed in young mice. Interestingly, also the survival post-stroke, which was decreased in old mice, returned to young mice levels when they were treated with infliximab. So, independently of the role of inflammaging in stroke outcome, we then decided to investigate a little bit deeper the role of different cytokines in stroke outcome, irrespective of age. So what we did was to measure different subtypes of cytokines in ipsilateral hemispheres of mice that had undergone the experimental stroke protocol. And interestingly, we found that IL-1 beta was significantly increased in the ipsilateral hemisphere as compared to the contralateral one. So was IL-6, which was rather expected because it's downstream of IL-1 beta. However, unexpectedly, TNF-alpha in this setting was not increased. And interestingly, also, the marker of neutrophil was significantly increased in ipsilateral hemispheres compared to contralateral one. Thus, we wanted to investigate whether selective inhibition of IL-1 beta could interfere with stroke outcome irrespective of aging. And here what we did, we had a slightly more clinically relevant setup where we administered the canakinumab surrogate antibody after the ischemic insult upon reperfusion, as you would commonly do in those patients that reach excuse me, the emergency room within 6 hours from, within 4.5 hours from onset of stroke symptoms. And despite of the post-ischemic administration of canakinumab, we obtained a very convincing reduction in stroke size. It was almost half the size as compared to the vehicle-treated mice. Once again, in line with the reduced stroke size, what we also observed was reduced edema formation. And what we also saw was an improved neuromotor deficit, as shown here by the lower Bederson scale, as well as an improved Rotarod test performance, as increased by the higher latency times to fall from the rotating rod. Here we also deepened a little bit the investigation into the molecular mechanisms, and what we saw was that in the ipsilateral hemisphere of vehicle-treated mice, there was a strong increase in neutrophil infiltration, which was also observed in the IL-1 beta antibody-treated mice, however, at much lower levels. So both IPSI versus IPSI levels were lower in the treated mice, but also the delta, the increase that you see in the vehicle compared to the delta you see in the treated mice was significantly reduced, thus indicating a lower infiltration of neutrophils. What we also saw was that the reduction of MMP2 we saw in the ipsilateral hemisphere of vehicle-treated mice was smaller than that observed in the IL-1 beta treated mice. And this was an important notion because MMP2 is known to directly and specifically degrade tight junction proteins that are responsible for blood-brain barrier functions such as Claudin-5, occludin, and VE-cadherin. And in this specific study, we didn't see an effect for occludin or for Claudin-5, but we saw an effect on VE-cadherin, which you can see is significantly decreased in ipsilateral hemispheres of control-treated mice, but it's not in the IL-1 beta antibody-treated mice, thus indicating that probably canakinumab preserves blood-brain barrier function and therefore decreases stroke size as well as edema formation. Lastly, again, looking at the IL-1 family, we also wanted to look at IL-1 alpha, which is known to be important for local amplification of inflammation as opposed to IL-1 beta, which is involved also in the systemic propagation. And what we saw here was we wanted to look at IL-1 alpha, and we used the bermekimab, which is currently developed clinically, a neutralizing antibody for IL-1 alpha, and it's under scrutiny in different clinical trials, concentrating on dermatological as well as oncological disorders. So again, what we did was to treat mice with IL-1 alpha post-ischemically, and here at first we did not see a significant effect on stroke size. And the dose we had used was actually in line with that being used in the ongoing clinical trials. And then while investigating, we went back to the FDA guidelines for translating human dosages into mouse dosages. And what we found was that when you go from human to mouse, you should multiply those for a factor which was calculated to 12.3, taking into account the lower surface ratio that is observed in certain areas. So we repeated the experiment with a higher dose of IL-1 alpha antibody, and in this case we saw a significant reduction in stroke size as compared to isotype control treated mice. Once again, this was not only observed from a histochemical level, but also by a neuromotor functional test, whereby the treated mice had a lower Bederson index as well as an increased performance in the Rotarod test. And then to try and understand if and how the effect of IL-1 alpha differed from that of IL-1 beta, we again looked at different mediators of stroke outcome, and we started by looking at all tight junctions but could not find any difference, unlike what we observed in IL-1 beta. So then we looked at cerebral endothelial, we looked at activation of the cerebral endothelium, and we found that VCAM was significantly decreased in IL-1 alpha treated mice, and in line with that also ICAM and even P-selectin, thus indicating decreased activation of the cerebral endothelium. In line with that, we also saw with IBA1 staining that the resident macrophages were decreased in the IL-1 alpha treated mice as compared to the isotype control. And finally, we also saw that MMP9 expression was decreased in the ipsilateral hemisphere of these mice as compared to the isotype control treated. And in particular, MMP9, which is of course important, an important mediator of inflammation, in this setting is very fundamental because it was shown by several groups to directly degrade and thus cause a neuronal cell death. So this was, at least in our opinion, the final mechanism by which IL-1 alpha protected mice or improved outcome in these mice. So in conclusion, after the few data that I could show you, we found that antibody-based neutralization of IL-1 beta reduces arterial thrombus formation, thus providing a possible molecular interpretation for the results obtained in the CANTOS. At the same time, selective targeting of inflammaging components, for instance, TNF-alpha, which we observed to be increased in old mice, restores stroke outcome to levels observed in young controls. And last but not least, inhibition of IL-1 beta and IL-1 alpha improve outcome after stroke, and via prevention of blood-brain barrier damage or endothelial activation, respectively, depending on the antibody that we have used in the study. I would like to thank you for your kind attention. I would like to thank again Professor Basso for the kind invitation. I'm very happy to answer to any of your questions.